So thank you, Dr. Khanna, for giving me this opportunity. And nice to see Dr. J.C. Mohan and other panelists. So I'm going to talk on newer lipid targets in ASCVD and PAD in South Asian population. And we all know that India is out of 8 countries. India is the country with the maximum population. The total population of India is almost equal to the total population of remaining 7 countries. If you look into the epidemiology, it's PAD is underappreciated global health problem, and there are about 236 million individuals worldwide as per the 2015 statistics. Prevalence in India is around 3.2%, Sri Lanka it's 3.6 and 3.5 in Bangladesh. Those individuals who have PAD have a high risk of lower extremity ulceration, acute limb ischemia, surgical and percutaneous revascularization, and amputation. Only there are approximately 50% of patients with PAD are asymptomatic, and those who have symptomatic, they have only 30% have typical symptoms of intermittent claudication. Peripheral and coronary artery disease are two sides of the same coin. If you look into patients of non-peripheral artery disease, approximately 30 to 50% of these patients have evidence of coronary artery disease, and around 15 to 25% have significant carotid artery stenosis. Those patients who have severe PAD, the prevalence of CAD may go up to as high as 94%. PAD is a marker of atherosclerotic disease burden, and it carries a higher risk of cardiovascular mortality. There's 6 times higher death from CVD if you have an associated symptomatic PAD, and 4 times more fatal myocardial infarction or CSD death, and 2 to 3 times higher incidence of stroke. Now, this is the curve, Kaplan curve, which is event-free survival by PAD status at 5 years for 6,818 patients. Green line is represents patient without peripheral artery disease. Red line is with asymptomatic, and blue is with symptomatic PAD. Compared with patients without PAD, both asymptomatic and symptomatic PAD had a significant increased risk of all-cause mortality or severe vascular event. And as compared to symptomatic PAD also have a greater all-cause mortality and a severe vascular event. That shows that even if patient is asymptomatic, they carry a higher risk of all-cause mortality and vascular event. And once patient becomes symptomatic, this becomes significantly more. Now, there are 13 risk factors which are associated with peripheral artery disease, and dyslipidemia is one of them, with an odd ratio of about 1.51. If we look into the different lipoprotein, LDL has a strongest association with an odd ratio of 1.78. However, in the physician health study, ratio of total cholesterol to total HDL cholesterol was found to be the strongest association with PAD. Heart protection study was the first study which demonstrated that there is benefit of treating peripheral artery disease with statin. It was found that there was 24% reduction in MACE when patients were given 40 milligram of statin, and there were about 16% relative risk reduction in the peripheral vascular event, which was driven primarily by 20% reduction in non-coronary revascularization. Then there were 26 meta-analysis of 26 statin trial, which also showed that irrespective of age, sex, whether you are diabetic or non-diabetic, whether you have peripheral artery disease or no peripheral artery disease, if you reduce LDL cholesterol by 40 milligram, there is about 24% reduction in MACE. This is a very good observational cohort study. in which it was found that statin have a dose-dependent effect on amputation and survival in PAD patients. It was found that amputation and mortality risk declined significantly with any dose of statin, means whether you give high intensity statin or low dose or moderate intensity, as compared to a group of patients who are only on antiplatelet without statin. However, the high intensity statin had a greater reduction in even uh, as far as mortality and amputation is concerned as compared to low dose or moderate dose intensity statin. Now, we have seen the benefit of high intensity statin in preventing amputation and mortality in patients with PAD. Remember that high intensity statin, as per this trials, meta-analysis of high intensity versus moderate intensity trial, the mean LDL cholesterol achieved with high intensity statin is just 70 milligram. And that was the reason why ATP3 2004 update recommended target of less than 70 milligram in patients with CAD or CAD risk equivalent in which peripheral artery disease were included. We have been following Americans and European guidelines and treating patients with coronary artery disease and peripheral artery disease with the recommendations by them. But what we see, despite these target being achieved, we have, 41% increase in CVD mortality from 1990 to 2015. As compared to American and European, where there is a decline by 50%. And this is primarily driven by a high prevalence of atherogenic dyslipidemia in Indian population. We have high level of triglyceride, low level of HDL cholesterol, high prevalence of small dense LDL particle with normal or mildly raised LDL cholesterol. We have other risk factors are also, there is high prevalence of other risk factors. And in addition to that, we have low control rate of hypertension, hypercholesterolemia, and diabetes. And in addition to that, poor awareness about CVD and primordial prevention. And there were no treatment guidelines for dyslipidemia among Asians till December 2014. And therefore, we thought that we need our own recommendation. LAI came out with its expert consensus part 1 and part 2. Part 1 was published in 2016, in which 153 experts were involved. There were uniform brainstorming sessions pan-India, and we came out with recommendations, and we came out with a table showing how to stratify your patients to prevent ASCVD. Here, patients of PAD, CAD, and cerebrovascular disease was kept in very high risk group, and those patients with very high risk group, the target of LDL cholesterol was less than 50 milligram. We were the first association in the world to recommend LDL less than 50 milligram in patients with established ASCVD. What was the justification of bringing down LDL to less than 50 milligram? This is one of the meta-analysis of statin trial, 38,000 patients, in which we can see that by reducing LDL down from 75 to less than 50, there was 19% reduction in events, cardiovascular event. Then came IMPROVE-IT trial, which was a long trial of 7 years, in which high-risk patient, ACS patients were included, and 29% of them had STAMI. And it was found that when LDL cholesterol was reduced from 70 to 53 by addition of ezetimibe over and above simvastatin, there was 6.6 relative risk reduction in patients when the LDL cholesterol came down to 53, which was, according to p-value, it was significant, and with an NT of 56. In 2015, again, PCSK9 trials, two PCSK9 trial was published. One was the Odyssey long-term phase 3 trial, and OSLER 1 and OSLER 2 study, in which in one of the trial, alirocumab was used, another was evolocumab was used. LDL was brought down from 120 to mean LDL of 50. There was 50% reduction in cardiovascular event. European guidelines, which was published in 2019, also recommended LDL cholesterol of less than 55 milligram in patients with ASCVD, whether either if it is clinical or subclinical. And this is what we recommended, that in ASCVD patients, we should have an LDL less than 50 milligram in 2016. Recently, we have published another paper in Journal of Clinical Hepatology, where we have added another risk group, which is called extreme risk group. And this is further categorized into category A and category B. Category A is CAD patient with one or more features of very high risk group. In this, we can have PAD also. Instead of coronary artery disease, if a patient has a peripheral artery disease with feature of high risk group, then it is considered as category A. When patients of coronary artery disease or PAD has features of very high risk group, then it is considered as, it is put into the category B. The point is that the target changes if patient is in category A, the target is of LDL is less than 50, but the optional goal is less than 30. Whereas in category B, which includes patients which are with a very extreme risk of having cardiovascular event, the target was of less than 30 milligram was recommended. The Fourier trial, this is based upon why we came to figure of 30 milligram. The most important trial which we took into consideration was Fourier trial, in which basal LDL was reduced from 30 to median of 30 milligram, in which we found that there was absolute risk reduction of 2.2 in primary endpoints and the secondary endpoints. In those patients in which there were about 3,642 patients with peripheral artery disease in this study. And if we take those patients with peripheral artery disease versus those patients without peripheral artery disease, the absolute risk reduction in patient with PAD was 3.5 with an NT of 29. And those patients without peripheral artery disease, the absolute risk reduction was 1.6 with an NT of 63. If we look into the major adverse limb events, with that we talked about cardiovascular event, but if we talk of limb event, it was found that it was significant in all the group, means all the patients, the whole trial, entire cohort, or patients with PAD and patients without PAD. But since patients with PAD, the absolute risk reduction was 0.9. It was more significant, and it was very insignificant in other two groups. And it is not only acute limb ischemia, which was significantly reduced. Even the major amputation and urgent revascularization was also reduced almost significantly. In IMPROVE-IT trial, those patients with acute coronary syndrome, if they did not have peripheral vascular disease, the absolute risk reduction was 1.7 with an NT of 59. Just mere addition of PVD, means if you add patients with PVD, the absolute risk reduction went up to 4.3 with an NT of 24. And if the patient happens to be diabetic, the absolute risk reduction went up to 9.1 with an NT of 11. So patient of coronary artery disease with PVD, peripheral artery disease, and diabetes, they fall into an extremely high risk group, and that is the reason we have classified these patients into the extreme risk group category B. Even the ODYSSEY outcome sub-analysis have shown that it reduces 31% PAD events when patients were compared with those who was given alirocumab as compared to placebo. Now, how we should treat PAD? Now, you have to control diabetes, hypertension, and reinforce lifestyle measures, and give high-intensity statin. If LDL is still more than 50, add ezetimibe. If it is still more than 50, you can consider goal is less than 50. Extreme risk group, level more than 50, add ezetimibe. If it is still more than 50, and if you have patients of peripheral artery disease plus coronary artery disease or cerebrovascular disease, or with one or more feature of high risk group, then consider PCSK9. The goal is less than 50, and optional goal is less than 30. And if the patient has coronary artery disease, peripheral artery disease, cerebrovascular disease, this is extreme risk category B. Here, consider PSK9, and the goal is less than 30. This is how we should treat patients of peripheral artery disease. So I conclude that peripheral artery disease is a highly prevalent atherosclerotic syndrome, and it is associated with significant morbidity, disability, and mortality. Remains an understudied disease population. Despite the significant limb and cardiovascular outcome in PD, there is a poor risk factor modification relative to other ASCVD like coronary artery disease, stroke. And this is the final risk algorithm, what I have described. And this is how we should proceed and treat our patients with peripheral artery disease. Thank you very much.
Thank you very much, Dr. Puri. That was indeed very good, as always. So I'll open this forum for question and answer if there's any from the panelists. I have got a few questions on the question and answer box. The first one is, what do you recommend in Burgess disease? Do you still think it's a atherosclerotic disease, and what level of lipid lowering you recommend there? Because it is one of the most severe form of lower limb peripheral vascular disease.
It all depends upon, see, if you look into our risk algorithm, and if for example, if we so if a person doesn't have any risk factors like hypertension, diabetes, or whatever it may be, so you classify that patient, and based upon the risk group, you have a target. The target of LDL can be 50, can be 70, can be less than 100. So if you keep that target of patient to less than 70 or 50, I think that is all we have to do. And if statin is needed, we do have to give statin to these patients. There is no doubt about it.
And what dose? Depending only on the lipid.
No, depending upon, we have to achieve target.
Right.
Can I ask a question, Dr. Khanna?
Yes, sure, sir.
Yeah. I want to ask Dr. Puri, what was the relationship of triglycerides and non-HDL cholesterol? Was that connected with the peripheral artery disease? Because we always thought that as a risk factor, high triglycerides and of course the non-HDL cholesterol will be in the same line. Did you find any relationship there?
See, non-HDL cholesterol and triglyceride they are the co-primary targets. Your first target is LDL cholesterol. You have to bring down the LDL cholesterol to the target which we have recommended. If you have achieved that target of LDL cholesterol, the next co-primary target is your non-HDL cholesterol. And non-HDL cholesterol should be within 30 milligram higher than the LDL cholesterol, not more than 30 milligram. So if you are given maximum dose of statin or azitamide, and if the LDL cholesterol target is not achieved, then you can add fibrate. Now coming to whether it can cause peripheral artery disease or not is its second question. That is, it is said that remnant cholesterol is more atherogenic than LDL cholesterol. It's because it contains fatty acid, and that causes a lot of inflammation, and a lot of cytokines are released. So if you have a high, remnant cholesterol, especially in a diabetic population or metabolic syndrome patients, your target is to bring down remnant cholesterol. What we have recommended in LAI is that LDL cholesterol, fasting LDL lipid profile is important because LDL cholesterol is our primary target. But we should have postprandial triglyceride and non-HDL level in all patients, because it is, for 18 hours or 16 hours in a day, we are in a non-fasting state. So we are exposed, our arteries are exposed to these remnant cholesterol, and which is what we may call as a triglyceride or remnant cholesterol. So we have to bring it down to a normal range of preferably less than triglyceride, preferably less than 100 milligram.
Okay, Dr. J.C. Mohan, would you like to conclude this, or you have?
I think it was an excellent talk. Few points are very clear that polyvascular disease needs aggressive treatment. Where, along with the LDL lowering, it would probably also need, along with the antiplatelet drugs, antithrombotic agents like vascular dose or rivaroxaban. And also the other aspect Dr. Puri rightly said was adequate control of hypertension and diabetes. Our only difficulty is we have absolutely no data what should be the thresholds of blood pressure control in peripheral vascular disease. We have absolutely no data because nobody has done a randomized study actually. We have data for cerebral vascular disease, coronary artery disease, renal disease, but we don't have data for peripheral vascular disease, and it's all a subgroup analysis, and the subgroup analysis obviously has its own issues. With regard to peripheral vascular disease and atherogenic dyslipidemia, which were being talked by Dr. Chandali, I think if we really do an analysis, we'll probably find the strongest relationship, but then it doesn't tell you whether it is a risk factor or a risk marker. Association between non-HDL cholesterol, or for that matter HDL to triglyceride ratio or TG to HDL, will be very strong. Unfortunately, we don't know whether this is an association or there is a causative effect of that. Those were some of my comments. But as such, I agree with Dr. Puri as far as the targets are concerned, and it also tells us that we have a long way to go with those targets. Probably at the moment we are not getting and achieving even in 5% of the individual. So we have a long road ahead of us. A long road ahead of us for polyvascular disease, for peripheral vascular disease, and that only tells us that just bringing down, based upon evidence, the threshold is not going to help us. We probably would have to do something much more than that.
Thank you very much, Dr. Mohan. So we are going to be closing here, and absolutely, I mean, it's the lipid tension which is the biggest risk factor apart from diabetes. So we have to tackle diabetes, insulin resistance, lipid tension, and many more procoagulant factors for vascular health. So, but what is very encouraging and what is very clear now is that our lipid goals have to be really low. We don't have to be on, and we have to be very careful to achieve those. You know, most of the patients and even physicians don't insist on achieving proper lipid goals.